everyone. Welcome to this session. I'm Lisa Adams. I'm coming from Dartmouth's Geisel School of Medicine in the U.S., and I'm joined by my co-chair for this session, Anna Mandalakis from Baylor University, also in the U.S. We want to welcome everyone to this session on preventing TB as we move towards elimination, programmatic realities, and achievements. We all know that if we're serious about our efforts to eliminate TB, we will need to target those individuals at highest risk for developing TB once infected, namely child contacts and HIV-infected individuals. We know that we need to reduce the reservoir of future cases to achieve this goal of elimination. Now, a vast body of evidence tells us that preventive therapy is effective at decreasing the likelihood of progressing to tuberculosis disease. Is there? Okay, we'll just work with the train running next door. Preventive therapy is generally considered safe and well tolerated, and it's been shown to be cost effective. Now, since 2010, WHO has endorsed the use of preventive therapy to treat latent TB in high-risk populations, which has resulted in many national programs in high TB burden countries adopting this policy. Yet despite the proven benefits and this WHO recommendation, we know that IPT is underutilized worldwide. Furthermore, among individuals initiating therapy, completion rates are often unknown or have been shown to be consistently poor. And this needs to change. In this session, we will hear from experts coming from high, medium, and low TB burden settings as they explore common barriers to preventive therapy, both in terms of uptake and adherence, while highlighting some successful strategies to prevent TB in at-risk and marginalized populations, including children, migrants, and people living with HIV. We're going to begin this session hearing from Dr. Kathy Mosher, who is the lead for the U.S.-Mexico unit at the U.S. Centers for Disease Control and Prevention, who will present on eliminating TB among newly arrived refugees, the guidelines to promote LTBI diagnosis and treatment prior to resettlement. She'll also be discussing the revised TB technical instructions and implementation challenges that have been both overcome and those that persist. Dr. Kathy Mosher, thank you.
Thank you. Thank you. Some of you may have seen in the program that Dr. Marty Cetron was to be giving this presentation. I'm not Marty Cetron. He's my boss at Division of Global Migration and Quarantine, and he's sorry he couldn't be here this morning. But what I'm going to talk about is the guidelines to promote latent TB infection diagnosis and treatment for entrants to the U.S. And I will talk about all entrants, but we'll have a sort of a special focus on child entrants. And unfortunately, as hard as I try, I have no financial disclosures to report. So as I said, I'll be talking about the pre-entry evaluation of U.S.-bound entrants, including immigrants and refugees, and talk about the follow-up of these individuals in the U.S. Now, in the U.S., each year, we have about 180 million plus entrants from other countries, most of whom are in this category of short-term entrants. We do no screening on people who are short-term entrants. We focus our screening on the 70,000, less these days, but in 2015 on 70,000 refugees who intend to reside long-term in the U.S., and on the million immigrants who also intend to reside long-term in the U.S., or who we call legal permanent residents, who are applying for legal permanent residency status. And I'll talk about 500,000 of these individuals who are screened outside the U.S. The other 500,000 are screened inside the U.S. So we'll focus on the refugees and immigrants. And these individuals are screened at about 400 sites worldwide in their countries of origin through groups of individuals and medical panels, or what we call the panel sites. Some are private physicians and others are associated with IOM. The screening that is done, sorry, I'm going to put this down until the screening that is done is promulgated by our division within CDC, and they are called the TB technical instructions. These are the instructions by which all the 400 plus panel sites screen individuals intending to reside long-term in the US for tuberculosis. These technical instructions started in 2007. Prior to 2007, the only screening for individuals, I'm not even touching it now. The only screening for individuals coming into the U.S. was for individuals 15 and older by means of an x-ray, and if that x-ray was abnormal, they would get a sputum smear, and only those individuals with a positive sputum smear would need to remain outside the U.S. until they got treated long enough to be sputum smear negative. Starting in 2007, the algorithm is as follows. All individuals 15 and older, get an x-ray. If that x-ray shows signs of TB, they get 3 sputum smears and now cultures. If any of those cultures are positive for TB, they are called Class A, and they have to be treated at the panel sites with directly observed therapy until cure. And only then are they reclassed to something called a B1, and I mention that because I'll mention it later, a B1 TB, treated TB, and allowed to enter the US. If they're sputum smear and culture negative, they are an untreated sputum smear and culture negative abnormal x-ray, Class B, and they are also allowed to directly enter the US. Now, how did children get into this algorithm? Children get into this algorithm because all children in WHO estimated countries that have a rate of 20 cases or more per 100,000 are screened either by skin test or an IGRA, by the panels. And if they are positive on either test, and it's the choice of the panels which test they use, then if they are positive, they are x-rayed. Now, this really didn't start out to be a method to identify children with latent TB infection. There were rules about x-raying children, x-raying all children, so there had to be an algorithm how to select out children who should be x-rayed, the x-ray being to look for active disease. But honestly, I'm not touching this. But it turns out that most children do not have active TB when they go through this algorithm, have normal x-rays, and therefore you have a whole group of children starting in 2007 that were noted to be LTBI and then were presented, allowed to enter the US as a Class B2, and were presented then to US TB programs to retest, to evaluate, and put on LTBI treatment. So as far as a method to find active disease, this new culturing strategy was very effective and actually found about 1,500 new cases a year before the individuals entered the US. And of those individuals, 72%, 75% in some years, this is for 2015, were found to be smear negative, culture positive. And so really, prior to this algorithm, 72% of the culture proven individuals had been allowed to enter the US with no treatment. Now, this was also shown very nicely in a review that showed this is 2007, when the new technical instructions went into, when they started. And previous to that, every year, these are the numbers of TB cases diagnosed in the US within 1 year of arrival to the US. So you can see there are about 1,500 a year. Once the new technical instructions using culture, and it took a few years to ramp up because there's a lot of countries and they had to build capacity for doing cultures, but once this started to ramp up, you can see each year 400 were diagnosed by culture through the new technical instructions to in 2012, 600. And you can almost see a direct correlation with how many fewer cases were diagnosed within 1 year of arrival in the U.S., showing that they really were well on their way to achieving a great reduction in individuals entering the U.S. with active disease. Now, how do the programs in the U.S. know about the B1 folks and the B2 kids who are entering the U.S.? Well, we have a paper-based system that soon will be electronic. Many countries already have an electronic system. But here's the overseas exam. The examinations for TB are on paper forms. These paper forms are hand-carried by the refugees and immigrants when they enter the U.S. They're usually successfully found and taken from them when they enter into the U.S. And then they're entered into a database that we call EDN. And this EDN system is then sent to all health departments where that individual intends to reside. And so they're notified a person is coming to you with a B1 or a B2 condition. And then also into this EDN, the health department enters the evaluation and outcomes, and were they able to put the person on treatment for LTBI, were they an active case. So it's really a nice comprehensive data system. One thing has been that there really has been mostly focus on the B1s, that is those individuals with abnormal x-rays when they enter, whether or not they had been treated overseas. And this is to just show these are some of the incentives, if you will, that are given to U.S. health departments by means of the CDC's annual program indicators. The CDC has no program indicators for state health departments in the U.S. about the B2 LTBI children, but they do have indicators and targets to incentivize TB programs to really do a good job at locating and evaluating the B1 individuals who have abnormal x-rays. And not only to be sure when they enter the U.S. to be double sure they don't have active disease, even those who had been culture negative overseas, about 1% end up having TB when they enter the U.S., but also because those with now stable, potentially stable abnormal x-rays, class 4s, are really at high risk for developing TB in the future. And so they also incentivize TB programs with their targets to find those people and put them on LTBI treatment. Now that does capture adolescents, because 15 to 17-year-olds are also x-rayed overseas. So a few kids get caught in this algorithm of high interest. Now, what about the rest of the kids? What about all those B2 LTBI kids that are entering into the U.S.? So this was just a look from 2008 to 2014 of refugees. Now, these are just the refugee children who were screened overseas. And what they noted was there was about 6,000 kids who entered over these years with LTBI. They did look at how they were screened overseas, which at that time was mostly through skin test. And they found that the follow-up in the U.S., as measured by the EDN system, was 79%. So fully 21% of the kids were never noted to be evaluated in the U.S. The U.S. programs evaluated in various different ways. They often repeated with an IGRA if the child had been skin tested overseas, repeated with an IGRA, and then 63% of these kids ended up with an LTBI diagnosis after evaluation in the U.S. But again, there were 10% of kids who never had a final diagnosis in EDN, which meant they may have started an evaluation, but they never got to the point where it was determined whether they have LTBI or not. So the upshot of this review was that you had 6,000 kids diagnosed with LTBI overseas. 21% did not have a documented U.S. follow-up exam. 10% who had a follow-up exam didn't make it to final diagnosis. There's also indicators in EDN of whether they were started on treatment. Of those who were diagnosed with LTBI in the U.S., 21% of those did not initiate treatment for LTBI, and of those who initiated, 50% did not complete their treatment for LTBI. So clearly, despite the whole front end presentation of these high-risk individuals with LTBI, the outcomes were less than ideal. They sliced and diced these group of refugee children by a variety of things to see what might matter in improving outcomes. They looked by country of birth, and it didn't seem to make a difference. None of this was statistically significant as to whether the kids started treatment or eventually completed treatment. They looked through a variety of parameters, but the only one that had any significance was how fast the child was started on LTBI treatment after arrival. And somewhat counterintuitively, the children did less well when they started immediately after entry. They did better when they'd been in the US a few months. And that's just a repeat. So the feeling was maybe these children do better after they've been in the US for a while because their families are more stable, they have more access to, they've already been enrolled in school, and so maybe you should be waiting until you try to start treatment on these children. But it's still even the children who didn't start treatment until after several months, still it was not an ideal outcome. So one thing that was considered at that time is because we treat individuals overseas for their active disease, maybe an answer, especially with short course LTBI treatment, maybe these kids could be offered treatment outside the US with higher success. So there was another study done to look at immigrant children to see if they fared any better than refugee children. And if you know how refugee children are handled in the US or refugees overall, there's very organized resettlement programs in the US. So you would imagine that if anyone did well getting onto LTBI treatment and being case managed, it would be the refugee children. And in fact, that's true. They found it every step of the way that immigrant children did less well. They had lower rates of US follow-up and lower rates of being started on LTBI treatment than the refugee kids, and lower rates of completing treatment for LTBI if started. So overall in this analysis, 30% of the children with LTBI completed their treatment, and so still far from ideal. So going back to the idea that maybe treatment overseas will work, and there's many different policy reasons why it can't, that presents difficulty to treating immigrant children overseas for LTBI. But this is just a brand new study. The protocol isn't even finalized yet. But the CDC, in partnership with UC San Francisco and the immigrant screening program in Vietnam, is going to pilot among these Vietnamese immigrants a study to assess the feasibility and acceptability of voluntary testing and short course treatment of LTBI of these US-bound immigrants. And the treatment will be voluntary in this study. And they say voluntary testing because this will be on individuals 12 and older to start. And the way it will work, at least in the current protocol, will be with the short course, INH and rifapentine, and participants who complete at least 8 doses by DOT overseas will be able to bring their 4 remaining doses with them and be linked to a U.S. health department. So this should initiate sometime in 2018, and it may form the basis of really being able to move down the age groups and to really start to be treating people for latent TB infection overseas. So I'd like to thank the people who are supposed to give this talk and the people who gave me their slides and do most of the research, and thank you very much.
Thank you very much for the presentation. It was excellent. We have time for one question. Yes? All right. So we're going to move on to our next speaker. So our next speaker is Dr. Alexander Kay. Dr. Kay is an assistant professor of pediatrics at Baylor College of Medicine, and he's the associate director for Baylor's Global TB program. He's based in Swaziland full-time, where he directs our Center of TB Excellence, which is a national referral center for childhood TB. And he's going to be talking to us a little bit about isoniazid preventive therapy in children and adolescents living with HIV, and give some insight and perspective on some challenges and behaviors.
Thanks, Anna. So thanks, everybody, for coming. I have no conflicts. So today I'm going to talk about, I'm going to do a talk with essentially the overarching objective is going to be to look at ways to translate IPT policy into approved practice, with a focus on our patient population at the TB HIV clinic that I work at in Baban, Swaziland. We'll quickly review current IPT recommendations. Next, we'll describe IPT prescribing among practitioners at the clinic, and the clinical impact of that prescribing on patients living with HIV at the clinic. And finally, we'll try to understand some drivers of intention to take IPT, particularly in our adolescent population, but also in primary caregivers caring for children living with HIV. Just to provide a little bit of context, all of this work was done at a pediatric TB HIV clinic in Swaziland, although we provide family-centered care involving the parents of children that are affected by HIV. Swaziland has a current HIV prevalence that's estimated to be approximately 27%. HIV-TB co-infection complicates 71% of all TB cases and 53% of pediatric TB cases, and there's a current estimated TB incidence of 565 per 100,000 persons. So as you can see, this is a setting in which IPT could have a profound impact if implemented correctly. I'm not going to spend too much time on this because I think everybody in this room is aware of the different WHO recommendations for IPT. It can be loosely divided into TB and HIV, and for children living with HIV, there's a recommendation for 6 months of IPT, even without prior exposure to a case of to a person with TB. I'm going to focus primarily on the HIV recommendations here, but as you can imagine, in Swaziland, this is an area in which there's an incredible amount of overlap in our populations. To take a look at current uptake, this is data from the WHO Global TB report from 2016. Currently in sub-Saharan Africa, approximately 39% of patients newly initiated on ART are being initiated also on IPT, so there's some room for improvement there, although you can appreciate the positive trend line, especially outside of South Africa and the rest of Africa over the last several years. IPT uptake has improved dramatically. In Swaziland, the estimate informally in 2015 was 15%, although I think this has probably improved pretty dramatically over the course of the last couple of years. So I'm going to talk briefly about a retrospective analysis on pediatric IPT use at our clinic. Just to provide some background, in Swaziland, IPT is actually recommended cyclically, so it's recommended every 2 to 3 years for children living with HIV. And there's been quite a bit of programmatic commitment to improving IPT uptake in the country over the last couple of years especially. We had the following questions. So 1, are certain pediatric patients less or more likely to receive IPT? 2, what's the effect of IPT on ARV adherence? This is a big concern among pediatric HIV care providers. And 3, what risk factors exist for developing TB after IPT? So to answer these questions, or to try, we looked at a retrospective cohort review of HIV positive children aged 0 to 18 getting care at the HIV-TB clinic in Baban, Swaziland. And even though this is a single site, it's a relatively large center, so it cares for approximately 20% of the children affected by HIV in the country of Swaziland. So to get at the first question, we looked at a cohort of children aged 0 to 18 enrolled between 2006 and 2016 and found a total population of approximately 1,800. We found that approximately 58% of those children had been prescribed IPT. And we found some predictors or some associations with an increased likelihood or decreased likelihood of receiving IPT. So age less than 4 was associated with an increased likelihood of receiving IPT with a multivariate adjusted odds ratio. Perhaps secondary to the providers understanding that children less than 4 are at increased risk for severe disease secondary to TB, and a decreased likelihood of being prescribed IPT in older adolescents. Prior IPT or prior TB treatment actually led to a decreased likelihood of being prescribed IPT. Not quite sure why this is. In my mind, a prior episode of TB would potentially mean that you were at increased risk for TB exposure in the future. But this is the association that we found here. And CD4 count less than 500 was associated with an increased likelihood of being prescribed IPT, again, likely related to providers' perception of increased risk for TB. Interestingly, ARV adherence less than 95% was associated with a decreased likelihood of being prescribed IPT. I think this is very likely due to the provider's concern about the impact of added pills on ARV adherence. We do have adherence greater than 105%, and that's because in our clinic we measure adherence based on pill counts primarily. And with pill counts, we'll often see people losing pills and or dumping pills prior to their visit to avoid sort of lengthy conversations about adherence. So I think this is a major point here. So what is the effect of IPT on ARV adherence? We found that in a subset of 586 patients who we had good data on ARV adherence for 12 months prior to IPT, they had a statistically significant decrease in ARV adherence during IPT, but we did not feel that this was a clinically relevant decrease in ARV adherence at 0.5%. Among this much smaller group that was having difficulties with ARV adherence in the year prior to IPT, we found they actually improved in their ARV adherence for the 6 months on IPT. They went up by 4.4%. So we thought this was interesting and reassuring to some of the providers at our center that were concerned about the impact that IPT was having on ARV adherence. We also looked at a smaller subset of individuals who had their first course of IPT at least 5 years prior to the end of the analysis. So this was approximately 300 children. And we found 2 predictors on adjusted odds ratio that were associated with an increased likelihood of developing TB after an IPT course. The first was not being on ARVs at the time of IPT initiation, which you might expect. And the second was having a CD4 count of less than 500. So to conclude, we found that there was no significant impact on ARV adherence secondary to IPT administration, which was reassuring. We found some populations that were less likely to receive IPT, and we thought that we could use this in education with providers throughout the country to talk about the fact that these populations may also benefit from IPT. And we found a subset of patients who are at increased risk for developing TB disease following IPT. And there's current recommendations for extended courses of IPT, and we wonder whether if we're able to look at additional data sets, we might be able to identify some subsets of pediatric patients that could benefit from a longer course of IPT, like the 36 months that is currently recommended for adolescents and adults. And absolutely, there's a number of limitations here. It's a single center retrospective analysis, and pill counts are not a perfect measure of adherence by any stretch. Okay. So next I'm going to switch gears a little bit and try to look a little bit more at the perspective of the adolescents and the primary caregivers that are being prescribed IPT in this clinic. And to provide a bit more background, there have been a number of studies done using behavioral science in sub-Saharan Africa to try to understand adherence to ART, but little behavioral science work has been done looking at IPT adherence. So our question was, what are the primary drivers of intention to take IPT in adolescents and primary caregivers when analyzed through the theory of planned behavior? And I'll take a bit of time to try to explain what that is. But essentially, we administered a structured survey that was designed by an expert in the theory of planned behavior to 56 adolescents living with HIV and 59 primary caregivers, predominantly of children living with HIV, who were being prescribed at the time IPT at the TB HIV clinic. We analyzed the survey data to identify correlations and predictive relationships between theory of planned behavior variables and intention to take IPT. So to provide a bit of background about the theory of planned behavior, the theory of planned behavior is used in multiple fields. So advertising commonly uses the theory of planned behavior, but it's also used in behavioral health science to explain predictors of the ability to complete difficult tasks. So smoking cessation is something that it's commonly used for, and definitely adherence to chronic medications it's also used for as well. So what the theory essentially says that intention to complete a behavior is essentially the biggest predictor of actually completing that behavior, which makes sense. But that intention is informed by multiple different factors. So to break down those theory of planned behavior variables, attitudes essentially means how the person feels about IPT. Do they feel that it's important? Do they feel that it's good and that it will prevent TB? And that, according to the theory, is informed by their individual knowledge about IPT and about TB and how beneficial IPT might be to them. Subjective norms essentially describes how the people immediately surrounding the individual feel about the intervention, in this case IPT. So are they generally supportive of the person taking IPT? Do they understand what it means? Normative beliefs are then specific questions for the participant about what those individual people, their family, their friends, their neighbors might feel about them taking IPT. And lastly, perceived behavioral controls is essentially the person's attitude towards how easy or difficult taking IPT might be, and that's informed by control beliefs. So asking specific questions about potential barriers towards them succeeding or failing in taking IPT. We also modified the theory to include stigma, which on some preliminary analyses had been important to primary caregivers giving IPT, and also attitudes towards the clinic. So are there any things that the clinic could do to make IPT easier for the patient? We found that overall, both adolescents and primary caregivers viewed IPT very favorably, with 85% of adolescents and 90% of primary caregivers feeling generally positively about giving IPT. And we did a multivariate linear regression analysis using the three main IPT variables: attitudes, subjective norms, and perceived behavioral controls. And we were able to predict a significant amount of variance in intention to take IPT, R squared of 0.49 and R squared of 0.40, both of which were significant for primary caregivers and adolescents. But I think we can really learn a bit more when we look at the individual theory of planned behavior variables. So when we take attitudes, again, most of the cohort felt positively about IPT, and it predicted a significant amount of variance in intention to take IPT as attitude. However, it wasn't at all informed by the individual's knowledge or beliefs about IPT or TB. which I thought was interesting. But what was heavily correlated with their attitude towards IPT were these external forces, especially in adolescence. So normative beliefs, subjective norms, and stigma beliefs. So the concerns about stigma in the community related to IPT and how the patient felt that their family and friends would support their taking IPT seemed to be more heavily correlated with their attitude towards IPT than their individual knowledge base. When looking at subjective norms, again, both primary and caregivers felt that overall the people important to them would be supportive. However, for primary caregivers, we couldn't identify a predictive relationship between subjective norms and intention. However, for adolescents, subjective norms predicted intention and normative beliefs predicted subjective norms. So external forces, again, seem to be more prominent for adolescents than for primary caregivers. Interestingly, when we asked about specific normative beliefs, how specific people in their life might perceive their IPT use, 33% of adolescents thought their neighbors would be supportive versus 55% of primary caregivers. So while at the same time their family members were very supportive in both groups. So we think that it's possible that adolescents may feel sort of a more shallow pool of support in their communities for this health behavior than primary caregivers do. And lastly, looking at perceived behavioral controls, again, we found that people felt that giving or taking a pill would actually be relatively easy, but when we dug down a little bit further, and looked at some control beliefs that predicted a significant amount of variance in perceived behavioral controls, transport costs came up significantly for both groups. So this was a major concern. Any increase in the amount of visits that IPT would require for these patients was seen as a major barrier for them taking IPT. And then looking at stigma attitudes, the first question about transport made us think about more community-based care, but adolescents are also extremely worried about community health workers and about them potentially disclosing to their community. So until we improve trust in the community health workers, we may not be able to successfully engage in more community-based treatment. And lastly, some barriers identified at the clinical level. So increased hours and decreased wait times were both identified as factors that would make completing IPT much easier and let people get on with their day-to-day lives. And so just to conclude, adolescents and PCGs were very positive about IPT in general, although I'm sure we're dealing with some response bias here. But when we look at the individual variables, stigma and normative beliefs seem to play a much more important role for adolescents. So external forces seem to inform their willingness to take IPT more than primary caregivers. And barriers seem less related in our population to pill burden and more related to things like transport costs and time at the clinic. And again, there's a number of limitations here. Single center, this is a sort of a special pediatric population in Swaziland, so it may not be representative. And we haven't yet been able to link intention to adherence. And that's it.
Thank you, Alex. Just to keep on time, we'll allow one question. Anybody in the audience would like to ask anything? Yes.
Mm-hmm. Yeah, that's a great question. You know what? Yeah, sorry, he was asking about what additional interventions might sort of improve the feelings of support that adolescents might have for IPT. So one of the things that we're hoping to look at is how, like Teen Club, for example, factors into how our adolescents feel about IPT and maybe integrating more talks about IPT at Teen Club. And then the other area where I feel like we could have some success with this are school-based interventions. That's a place where we could get a lot of adolescents, both HIV positive and negative, together and talk about some of these issues related to TB. So those are the two areas that I've thought of to try to work on that. Thanks.
Thank you, Alex. Move on to our next speaker, who is Kuda Takarinda, who's an operations research fellow with the TB Union and works with the TB department of the Zimbabwean Ministry of Health and Child Care. And he'll be discussing his experience, including their successes with rolling out isoniazid preventive therapy among adults and children living with HIV in both rural and urban settings in Zimbabwe. Thank you.
Thank you for the introduction. Morning, everyone. So I'm going to speak on country experiences in scaling up IPT among HIV-infected patients in Zimbabwe. I have no conflicts to declare. So the outline for my presentation, I'm going to look at briefly the global and regional epidemiology of TB HIV, the country epidemiology, and then move into the national rollout of IPT in Zimbabwe, and then some best practices and challenges that we've faced as a program. So it goes without mention that HIV-associated TB is a global burden, with 1/3 of all people living with HIV being infected with latent TB, and that HIV-infected persons are at higher risk of developing TB than those who are HIV negative. And that despite the protective effect of ART, TB is still common as an illness among HIV-infected patients, and that it is also a leading cause of death. However, fortunately, TB in people living with HIV can be prevented and can be cured. This slide just shows a systematic review and meta-analysis that was done by Gupta et al., which in summary shows that there are a lot of missed TB cases that occur among patients who die that go undiagnosed, and clearly indicates that there's need for intensified TB case finding within people living with HIV, particularly in HIV programs, amongst those that have been enrolled in HIV treatment and care. Also, to add on to that, despite the great protective effect of ART alone in reducing TB incidence, and also the effect of IPT alone, there's an increased synergistic effect of providing both IPT and ART amongst people living with HIV. And this has been shown in studies that have been done in Brazil, South Africa, and Botswana. Hence, again, showing that ART alone cannot do the job of preventing TB. So there's need to actually scale up and roll out IPT within HIV programs. Again, looking at mathematical modeling, we see that we need to do business unusual if we're going to meet the NTB strategies of eliminating TB by 2035. And one of the strategies towards doing that, other than using shorter TB regimens for treating those patients with active TB, there's also need to treat patients with latent TB. So looking at the epidemiology of TB, HIV in Zimbabwe, Zimbabwe is amongst the 14 countries globally with a triple burden of TB, TB-HIV, and MDR-TB. According to our last population HIV impact assessment, our prevalence stands at 14.6%. Our TB incidence is 242 cases per 100,000 population. And TB HIV co-infection is similar to Swaziland, affecting every 7 in 10 patients. We also have a high burden of MDR-TB, affecting 3.2 and 14% of both new and retreatment TB cases. This slide here basically shows TB case notification rates in Zimbabwe. As you can see, from about 2000 to around 2004, prior to rollout of ART, we had an increase in TB case notifications. And then With the intervention and rapid scale-up of ART, we have also noted a decline in TB case notification rates. So we assume that ART has played a role in terms of lessening the burden of TB amongst HIV-infected patients. But however, key to that is if we are going to further decline TB cases in the country, given the high HIV burden, we probably need to also look at other innovative strategies such as IPT to further lessen TB cases in the country. So in line with WHO global guidance, the country adopted the 12-point WHO strategy for collaborative TB/HIV activities. I think as a country, we have done well on point A, which is establishing collaborative activities between in the National TB Program and the National AIDS Control Program, and also in increasing, lessening the burden of HIV amongst TB patients. That is through HIV testing, provision of CBT, and also initiating ART amongst patients who are diagnosed with TB/HIV co-infected patients. Also to further mention that also screening has been rolled out also amongst presumptive and not only active TB patients. However, okay. However, the country has somehow had somehow lagged behind in terms of intensified TB case finding, which was adopted in 2010, and furthermore, rollout of INH preventive therapy was only started in the country in 2012 with support from WHO. So this slide basically shows us the progress in implementation of the national ICF IPT program. So it started out in 10 sites, 10 feasibility sites, and that started off with adaptation of WHO ICF IPT guidelines, and then that led to revision of our monitoring and evaluation data reporting and recording tools. And then stakeholder sensitization meetings were also conducted at various levels on ICF and IPT. And that involved at national level, at provincial level, and then down to district level, which was then cascaded to the periphery health facilities. This sort of enabled, though it was being done in 10 sites, this also enabled that district health and provincial health executive teams could actually offer routine support supervision visits to these facilities in order to see how the program was being implemented. And then capacity and skills building workshops were also done amongst healthcare workers who were actually providing the ICF and IPT services in the facilities. And then, so this feasibility phase occurred between January 2012 and December 2018. And at the end of that period, a feasibility phase of the program was conducted. And that included conducting an operational research study with the main question in the program being, are patients completing their IPT treatment? And then post that, in the post-feasibility phase, IPT was then scaled up to other facilities. And we saw a move from 10 facilities in the initial phase to 708 facilities by end of Q1 in 2017. So basically, out of the OR study that was conducted as part of that feasibility assessment, our study findings, based on retrospective records review, we found out that completion rates for IPT were fairly high, with 81% of patients that were enrolled in the study having completed their IPT. And this was measured as patients who took their monthly pills. And then at that time, IPT was being rolled out on a monthly basis. And And then timely arrival for the next scheduled review visit was the basis of defining which patients completed and which patients did not complete IPT. We also looked at factors that were associated with non-completion of IPT, and these included non-synchronization of IPT and ART pill pickup visits amongst those patients that were on ART. So like I mentioned, IPT in the feasibility phase was being rolled out on a monthly basis, and ART basically in the program at the time, before differentiated HIV care models were adopted, were rolled out on a 2-monthly to 3-monthly basis. Also, they were reported intermittent IPT drug stockouts in the pilot facilities, and this was again associated with not completing IPT. And then, particularly in groups that were on pre-ART, and this was in the pre-treat all era, and those patients with a history of defaulting ART were also linked with not completing IPT. So all these things also led to program adjustments going forward, whereby IPT was then dispensed at the same time as a patient was collecting the ART drugs. And also we tried to ensure that there were no stockouts at facilities, and also enhanced counseling and follow-up of patients who were on pre-ART, and also where the history of defaulting ART was also emphasized amongst health workers. So this slide shows us how we scaled up ART in the country. Like I mentioned, we started off with 10 sites, and as of Q1 2017, we had 708 sites providing IPT. In terms of the numbers also increased from 98 to about 231,000 patients. We also tracked to see how many patients developed TB whilst they were on IPT. As you can see, I think the peak of TB cases that active TB that developed amongst patients on IPT was 1.4% in the 2014 cohort. Again, this is cross-sectional data, but I think the point to emphasize there is that intensified TB case finding remained a part of the program. So even if a patient was on IPT, at every contact with the health worker, they were assessed to see whether they had any signs of TB using the 4-symptom WHO recommended checklist. And if a patient was identified to have TB, they would then be immediately stopped on IPT and started on anti-TB treatment. We also monitored for development of toxicities or any side effects that included any rashes, etc., etc. And again, these were below the WHO targets of 2%. However, since it's cross-sectional data, which was based on aggregate data that was reported to national level, we're then not able to see completion rates. So again, from a cross-sectional point of view, we are not able to really tell what the completion rates were. However, what we did note is that despite the number of reported toxicities and side effects, these were not then actively reported in the adverse drug reaction reporting system, which would then tell us what caused these toxicities, the severity, the duration of the adverse events, and when they started. So which is very important information that the program would have really benefited from. So for the January to June 2014 cohort, we again conducted a similar study. Basically, this time around, we used data from facilities that had what we call the electronic patient monitoring system, which is a patient-level data collection system. So of those sites, we looked at 1,772 patients, and of these, 97% did complete their IPT. So again, this was just a sample of those sites that had that electronic system, which now has been scaled up to about 662 facilities countrywide. Sorry. So, however, there were also some suspected cases of INH hepatotoxicity, and this was prompted in November of 2014 by a case of a health worker, female health worker, 56 years old, who was suspected to have liver failure and was referred to one of the central hospitals in the country. The patient deteriorated subsequently and died on day 5, post-admission into intensive care unit. And then there were also some suspected cases which raised questions around IPT that were reported by physicians in Harare, which is the capital city. And out of these, in fact, these amounted to a total of 23 cases that were reported to the ministry by April of 2015. And this prompted the Ministry of Health to set up a task force, including physician experts, program managers, an MPH FET program officer, who looked into these cases and tried to identify what actually was happening. So of all these 23 cases, it only turned out that 8 were actually attributed to IPT, with the remainder being patients who were either on full anti-TB treatment or had severe injuries due to other reasons. So characterizing these 8 patients, they were all female with a median age of 38 years, and their duration on ART ranged from 3 to 11 years, and with fairly high CD4 counts with a median of 620 cells per microliter. And these patients had been on IPT for a duration of 3 weeks to 4 months. And looking at these 8, 7 of them were on concurrent Tenolam E, and with the other patients being on Tenolam and on a nevirapine-based regimen, of whom 3 deaths occurred and 2 were on EFV and 1 was on a nevirapine-based regimen. This is despite that our guidelines recommended that any patients at that time of those who were on a nevirapine-based regimen were supposed then to be switched to efavirenz once put on IPT. These patients did not show any additional concurrent medications with hepatotoxicity effects, nor were they on, did they have any history, at least documented, of use of traditional medicines. Presenting symptoms included earlier onset of nausea and vomiting and jaundice, and onset of symptom prior to presentation ranged from 6 days to a month. And of these clients, they had prior visited another health worker prior to admission, and initially managed as cases of acute gastroenteritis. Again, this information I've already provided that characterized the cases that died. So of the 3 that died, the remaining 5 completely recovered and were discharged. So I think out of this prompted some questions as to was the extent of the problem and the reported incidence of these suspected hepatotoxicity effects in line with what is expected of patients who are on INH exposure. It also prompted questions around current IPT prescribing practices among clinicians, given that one particular patient was on nevirapine at the time that they were on IPT. And then also, it prompted the program to ask whether it is really necessary, perhaps maybe going forward, to re-stratify clients eligible for IPT. Like, should the focus be on patients of a particular CD4 count group, or is gender something associated, something to look into in terms of stratifying eligible patients? And also whether the it was a pharmacovigilance issue related to the batch of INH, given that these cases were more or less reported between November of 2014 and April 2015. And Going forward, even as the numbers scaled up, the number of cases reported has really been 1 or 2 cases. And any possibility of interactions with efavirenz. So looking into key areas of the program and challenges that we faced and follow-up actions that we adopted, we realized that as a program that there were issues around coordination of IPT as we scaled up, that there was weak coordination and management systems necessary to scale up IPT nationwide. And in response to that, we established provincial TB-HIV committees. These were drawn from existing district and provincial health executive teams. So these basically would actually spearhead and coordinate, scale up of IPT within their respective jurisdictions. We also noted that there was inadequate capacity amongst health workers to offer quality, comprehensive ICF IPT services as part of TB-HIV collaborative activities. And as a result, we conducted trainer-of-trainer capacity, multidisciplinary provincial teams that then were responsible for then training health workers in the different administrative jurisdictions in the country, and also to complement this with post-training support through clinical mentorship strategies, since the country was moving away from didactic trainings. We also noted that there were weak downstream supply chain issues, which resulted in stock interruptions in some facilities. And as a result, we also capacitated health workers on the medicine stock management system for IPT. We also noted that at national level, even though drugs were cascaded down to provincial level, sometimes there were issues where health workers would run out of drugs without prompting provincial level. So to also mitigate that, we also established social media platforms like WhatsApp groups, whereby these would include health workers at the periphery facilities and also pharmacy managers. So this would actively prompt them to alert pharmacy managers where their drug stocks were running low. Issues around advocacy and community mobilization. We noted that there were communication gaps between the community and health facilities, resulting in low uptake of IPT. So in an attempt to improve uptake of IPT, we also conducted community dialogues and sensitization meetings with community-based health workers who then link up with people living with HIV. And we also printed and distributed IEC materials explaining the benefits of IPT. Also, another issue was issues of attitudes and practices amongst health workers, particularly perceived notions that the IPT ICF program was a vertical program, so we integrated that into other health programs. And we also noted, lastly, that patients also reported issues of high pill burden. So initially we started off with 100 milligram tablets and then moved over to 300 milligram tablets so as to lessen the pill burden amongst health workers. So I think in essence, our IPT program is scaled up, but we've had issues with low uptake, as only about 31% of eligible patients are actually accessing IPT. And that we feel it's important as a program that right messaging and appropriate management of adverse events is key for the program. And we also need operational research to answer key questions that can build in buy-in. Thank you.
Thank you very much for sharing your program with us. Wonderful presentation, very impressive work that you've been doing. Dr. Takarendra will be here at the end. If anyone has any specific questions for him, you can come up and speak with him or in the open session. And we're going to move on to the next speaker now. So our next speaker is Dr. Andrea Cruz, and she's presenting on behalf of Ana Maria Galvez. Dr. Cruz is an associate professor of pediatrics at Baylor College of Medicine and the director of Baylor's Pediatric TB Clinic. And Dr. Cruz is actually going to be sharing with you some details of a new program that our Global TB program has initiated with partners in Colombia, including IOM and the Baylor Children's Foundation Colombia.
Thank you very much. Thank you for the invitation this morning. I'm presenting on behalf of one of our Colombian partners on the ground, and by definition, since we're earlier in the process than some of our colleagues who've spoken before, this will be much more of a descriptive study, so bear with me. So a bit of background on Colombia. Colombia has a population of about 50 million and a TB incidence rate of about 31 per 100,000, which is very much in line with what's seen in many of the Americas. The population in which we did the study has a population in one of the states in Colombia that's called La Guajira, which is in the northeastern part of the country, has a population of about 1 million spread over a very large geographic distribution. And so you can see from this population pyramid, this is very much a young population structure. The Guajira is shown at the top here. It's a peninsula that's adjacent to the Venezuelan border. And a little bit more of an inset map, you can see that there's not a lot of roads that sort of crisscross this area, which provides a great deal of obstacles and challenges when you're thinking about healthcare delivery to very much a disenfranchised population. So while the TB incidence rates of TB are low in Colombia as a whole, as is the case in many of our countries, that burden of disease is not equally spread out over the country, and indigenous populations, we think at least, because we don't have great surveillance data, are disproportionately affected. The population which we're working is called the Wayuu. They're the largest indigenous population in all of Colombia. They are a semi-nomadic population that survives on subsistence farming, herding of small animals. It's a matrilineal society, and by pretty much any health indicator that we might use, they have very poor health metrics. They live in dwellings like this, which from a TB transmission standpoint seems like a perfect cauldron, very small, dark, poorly ventilated homes. And it sort of sets your idea of what is a household contact, frankly, a little bit on edge, because there are these small communities, and anytime anyone comes up to the community, the entire village sort of congregates around one of these small homes. So it really, when we think about our definition of a household contact, I think we might really need to sort of think about how do we go about redefining that for this particular population. You can't have any pediatric study without really acknowledging that children have a lot of time that they spend with their fingers in their nose and other orifices. And they also sort of live communally with herding animals, which makes me also think about the potential role of Mycobacterium bovis in here. These are quite dense dwellings, and they're often multi-generational dwellings. So you have a lady who's breastfeeding a child here in the background. This lady had been diagnosed with TB and stopped therapy after just 4 months. And this is something that's commonly described when you go into these communities. One of the things we wanted to do was we wanted to really sort of set this up and really add it on to an existing program, because we thought that from a sustainability standpoint, that would very much be our way to go. So what we did was we actually, there was a program that we already had on the ground there that was specifically targeting child malnutrition. Malnutrition and actually starvation is one of the most common causes of death in the under 5 population in this indigenous population. And the program is called SAIL, Salud y Autosuficiencia Indígenas en la Guajira, which means health and self-sufficiency among indigenous populations in this department in Colombia. And it's a partnership with Chevron and sort of a Walmart equivalent, really, in Colombia that's called Grupo Éxito. And here, we already had 20 community health workers called promotoras who were already on the ground. They were folks who lived in the indigenous communities, spoke the language, were really already very much a go-to for the folks in that community as far as health resources. So we thought, are there ways that we can add contact tracing and symptomatic screening to the interactions that these individuals are already having with these children? Here you can see their main thing that they're looking at is child malnutrition. So here they're weighing a child. They have interactions with these kids on an every 6-week basis at the minimum, and they already have referral patterns in place for what to do with the severely malnourished children. So there's already a scaffolding onto which we can potentially add these programs. This is a picture of one of the roads. So there are droughts here that occur for long periods of time, and the times that you do have rain, even if it's small amounts of rain, you have sort of widespread flooding. that really makes delivery, delivery of care really quite challenging. So how did we set the groundwork for this? So we went down in March for a workshop that we conducted with the Ministry of Health, and we had representatives in TB control from all the 30-plus departments within the country of Colombia, and really recognizing that childhood TB was very much a vulnerable population, and recognized that there are ways that we can improve the care that we're delivering to these children. It was also really an opportunity for folks from different parts of Mexico, from Colombia, to very much share best practices. And we knew that there were some regions where the TB control, even among disenfranchised populations, was actually quite good. And so there were tricks of the trade that they were able to share within their own country. We went back down in August for a site assessment, and at that time we looked at available resources and provider knowledge. And this is not just provider knowledge among pediatricians, but provider knowledge among everyone in the healthcare system with whom they might interact, starting with the community health workers, all the way up to the pulmonologists at the referral hospitals in one of the larger cities in this province. And we're actually going back down next week to do more of a training session to try to really increase knowledge and figure out what next steps were going to be for this population. So one of the things that we're really focusing on is provider education. As is the case in most countries, the amount of tuberculosis that individuals are exposed to in medical school and in nursing school is a very, very small percentage of the total curriculum. And many of the providers in this area are actually providers who are stationed there for their rural service year. And so there's a lot of personnel turnover, which again makes maintenance of best practices really quite difficult to do when you're having so much staff turnover. What we're hoping to do is do symptom-based screening, and I'll talk about one sort of unique challenge in this area to doing that, and then active case finding, really hinging mostly on the promotoras who have quite a big footprint in the community already. Furthermore, we're hoping that we can identify close contact of cases. Really, IPT has not been done much in this particular community at figuring out how we can at least offer to the under 5 population of children who are in the same communities as cases. And overall, we wanted to really increase community knowledge of tuberculosis within this population, hoping to destigmatize it more so that hopefully people would be more prone to coming forward when they had symptoms. So what are the challenges? So this is sort of a geographically unique place. It certainly was like no place I'd ever visited. So it's a desert right on the Caribbean. So what's one of the problems with a desert on the Caribbean? Well, it's that you have huge amounts of aerosolized sand. So everybody there has a chronic cough. I was there for about 3 days, and I had a subacute cough, I think, at the time of my exit from there. There's probably a lot, frankly, of undiagnosed asthma in this population as well. And both those have really made it that you can't use cough as a screening tool. And when you think about it, it's integrated in almost every symptom-based evaluation for childhood and adult tuberculosis. And then you superimpose that on the lack of diagnostic testing that's available. Very difficult to get chest radiographs, and really tests of infection are unavailable entirely in this population. And for those of you who are sitting in the back, that fence is actually made out of cacti. So it's a very good use of available resources, and it probably means that your farm animals are not going to try to escape the pen in which they're located. So what are some opportunities in this population? So clearly there's some barriers, but there are a lot of opportunities as well. So these community health workers have very strong ties already to the existing community. They have trust in a community that's very much been hesitant to accept Western medicine. And having an inroad in there and people who speak their language and understand their cultural background is really quite invaluable. Baylor is already seen as a provider of malnutrition care, so it's not an illogical next step that they would then be having forays into other aspects of child health services. And then we wanted to add screening to an existing infrastructure. And sort of this Venn diagram is illustrative of the fact that, here we know that there's huge overlap between TB and child malnutrition, and it's really not something that had been explored in this specific population. So I'm going to end, just to try to get us a little bit back more on schedule in case there are questions, with what are some next steps in terms of TB elimination in Colombia. And this is something that we came up with a lot of stakeholders at the table, both almost all from within Colombia itself. So part of it was increasing visibility in terms of policy and recognizing that TB had to be seen as a public health priority. And I think this is always a challenge in countries that are intermediate incidence because it's not seen to be as much of a health problem as potentially some other chronic diseases. Recognition of who were the key stakeholders who had to be at the table, and I think this is important whenever you're doing outreach and trying to establish programs in countries that you're not as familiar with as you are in your own region. From a technical assistance standpoint, clearly there was huge need to educate about TB. So for example, the community health workers in this area had no idea how TB was transmitted, had no idea that TB was preventable or curable. So clearly inroads that can be made in terms of this. Sharing best practices, and there are different ways to do that, whether it's at conferences, whether it's in written formats, et cetera. And then quite a bit on operational research, which is always challenging because it's almost impossible to find funding for this. But needing technical assistance to accompany any kind of strategic plan. How do you implement monitoring and evaluation programs in systems that are very much paper-based if documentation is done at all? And potentially creations of centers of excellence where these children can receive care. And with that, I'll stop and I'll take any questions if we have time for questions. For one question?
Yes, we have time for questions.
Okay, no problem. Thank you. All right. Thank you, guys.
Hey, Andrea, I have one question. Andrea, I have a question. Just because this is unique to the Columbia setting, I wonder if you could just talk a little bit about the private sector and the challenges with the private sector, because so this is a it's middle income country that has a large private sector that's involved in TB care and treatment.
Yeah. So Colombia has universal health access. So as an American, I'm incredibly envious of this model since we have been unable to achieve that in our own country. One of the things, though, is that the universal healthcare model is very local in nature. So if you have people who live in one province or one municipality, they need to really seek healthcare in that one area. So if they need to go to another place for specialty services, that becomes quite challenging from a standpoint of figuring out how that's going to go about being financed. The other thing is that while everybody, has some level of private insurance, which can be supplemented with, or of public insurance, which can be supplemented with private insurance, part of the issue is that the moment a patient is diagnosed with TB, to some degree, my understanding is that the private sector sort of washes their hand of that problem, and it becomes an issue that is entirely dealt with within the public sector. And to some degree, this is really good as far as potential for standardization of care and building up expertise in specific areas where people are more accustomed to dealing with tuberculosis. But it does mean that there's sort of financial abdication on the part of the insurance companies, and then a lot of that burden is then put into the public sector. And there's no particularly good solution that I don't think that has been found to that. Is that what you're referring to, Anna? Yeah.
Thank you.
All right. Thanks, guys.
So I just want to take a moment and recap what we've done so far this morning. So I think everyone in the room prescribes to the concept that in order to achieve the ambitious NTB strategies, we'll need to narrow the case detection gap in child TB and also improve IPT uptake and completion. And I think that the 4 speakers we had this morning were actually very inspirational. Dr. Moser showed us that it's actually feasible to implement pre-immigration LTBI screening and promote IPT at a global scale. Dr. K actually demonstrated the acceptability of IPT in caregivers of children living with HIV and adolescents living with HIV, and really importantly showed that ARV adherence is improved by IPT. Dr. Takarinda actually illustrated the feasibility of scaling up IPT in people living with HIV at a national level. And Dr. Cruz actually gave us a wonderful example of taking TB case finding and promotion of IPT into the community, into a non-traditional TB setting, and piggybacking that on a non-traditional TB program. And our last presentation of the day is actually going to be a video presentation given by Dr. Detchen. So Dr. Detchen is the child TB point person at UNICEF, and she actually has been working with the global TB community, child TB community, on approaches and theories surrounding the integration of child TB care within non-traditional TB settings.
And this is just a message to the AV people in the back. So her PowerPoint will run automatically, but we need to turn up the sound. So she pre-recorded her talk since she could not be here today. And so we thought we would save it till the very end, run it. Whoever can stay, you are welcome to. We hope many of you will, but if you need to leave, you won't offend the speaker since she's not here. But if we could, is there a way to run it with sound? It worked when I tested it yesterday, but so I'm hoping that we can get the sound to play so we can hear Ann Detchen's voice as well.
So I don't think that we're going to be successful in playing Dr. Detchen's presentation, but just to give you a brief overview of this initiative, really within the child TB community, the TB roadmap was launched in 2012, and that thinking really is to promote the integration of child TB into non-traditional TB platforms, including maternal neonatal child health settings, malnutrition clinics, pulmonary